Little clarification at the break. We're now getting into a topic that I love talking about. And unfortunately, I could spend, Bobby, way too much time on this topic, like a lot of things. So I'm going to pull us in a little bit, go over kind of a overall view, clinical view, keep it simple type of thing, view of what we would do to keep ourselves conscientiously aware of what I call whole control. Now remember earlier today, when I talk about the acetabulin, it's all about the A on F this week, right? How do we keep the A on the F? How do we manage our A's are more important to me right now, Karina, than managing the femurs. We got to manage femurs, don't misunderstand. But you have to have insight to what you're doing with that A before you can manage that femur. And to manage that A, remember we talked about the hole that manages the A? It's the obturator. Let's think about this. I'm in a position where my left side is the compensatory side, Katie. So if I'm on my right side and I have an A that's mainly covering that femur, not for compensation, but for real life daily activities. You know, I'm a guy that likes to do as much as I can with my left side. My calf showed you that. So I like to be on my left side. It just keeps me somewhat balanced. It doesn't keep me fully balanced, but it somewhat keeps me balanced, okay? If I look at the patients I work with, they have better ability to move themselves over their A on the right side than they do the left. So their position that they're in when their A is over the femur, when it's positioned in internal rotation, they don't need as much stabilization from the obturator, if you will, at that point. Because they're kind of over, their acetabulin's over their femur. They have it. Now, the left AFER, activity that corresponds with that helped them get over there. But over time, Lydia, they don't even use the left side to get over there. They pull in their adductor to get over there, they find their femur, and they got it. It's just so easy for them to do because mechanically we're wired that way better and asymmetrically, neurologically driven that way better and respiratorily driven that way better. When we want them to get over to the left side, so we're not even going to talk about whole control at this point. Okay, at this point, that's our natural state of being. You can be in a position where both of your pelvises are forward and you don't have good whole control on either side. They're both not doing very well. Both of the foramen magnums are in a position where they don't have the correct orientation of hamstring to femur and femur to hamstring, or this hole to this hole and this hole to this hole. They're not there. But before we go there, before we talk about that person that's got that on both sides, let's talk about what we would do with no matter who walks in your clinic. A person that has a pelvis that's forward on both sides or a pelvis that's forward only on the left side. When you're forward on the left side and you got that good awareness of right AFIR, and then I want you to learn how to do that on the left side, to shift you over to the left side. To do that, you have to have really good ability to generate that movement over to that left side. That requires right whole control, right triosseous control, because you got to get out of the state of adduction and into a state of abduction, into a state of flexion, and into a state of external rotation on that right side. Those things add up to obturator, to glute max, to piriformis, with the exception of the obturator, to your triosseous. Don, when I hit this, am I just scratching everything up? Probably. Once in a while. So when I want the triosseous muscles on the right side, that would be the glute max, the iliacus, and the piriformis pad, to give me the ability to push myself over to which side? The left side. So I need more whole control. When I leave this hole, I need more whole control from this side to get me over to which side? The left side. I need an obturator that's going to get me over there. Once I get my holes moved over to the left side, Then I need better AF hold control, FA control of my acetabulum on my left side. Does that make sense? So we're going to start off by telling you on page 30 what we mean by pitons and what we need to have first, second, and third, Lydia. So desirable real estate for acetabular hold control. That acetabular hold control requires these things to happen first. Number one, we need a glute max that's going to pull the femur into the acetabulum. That's your first piton. You know what a piton is? When you climb, and I guess there's a new word for this, but when you climb rock, when you go up a mountain, you tap a piton in and it's got a little loop, it's got a little spike. You tap it in and you really find something that's not loose that's going to pop out of. So you find hard rock and you pop that piton in there and you start tapping it. If the rock breaks loose, it's not a good solid hold. You find a real strong rock, drive that piton in, it's got a little loop, you tie a rope to it. There's your first piton. Then you climb a little further up the mountain and you tie a second one. You tie a second piton or a rope to a second piton that you found a good anchor for. And I'm not a rock climber, but I think they've got 3 or 4 of these things. So in case one goes, Pat, there's one there for you. Another one goes, hopefully you got another one holding you up. And if you don't have another one in there, you're dead. Adios. Okay? But those are called pitons. So the first piton, the first thing you got to be able to do is you got to, and I put a little asterisk there, this secure A via attachments at lesser and greater trochanters with innominate bones now serving as direct attachment sites to each other. And where you see that little pulley, that little asterisk, that relates to number 3 and 4, because we're going to talk about A on F. But to begin with, we got to get this glute max to pull your femur inside of an acetabulum. It's got to be pulled in that acetabulum. Remember, the right side, you don't pull a femur in the acetabulum. You're putting the acetabulum on the what? Femur. So I want a glute max on the right side to pull my femur into my acetabulum. As it pulls my femur in the acetabulum, that should allow my acetabulum to start to shift over to which side? The left. That's called external rotation. The glute max does not internally rotate you. It externally rotates you. So once I got that femur moving into that acetabulum, I'm starting to shift over to the left side via ER osmosis, if you will. Then I'm going to kick in an obturator on that right side. And could you take your pencils and pens and circle that second sentence or second number? Obturator. The obturator is the one that's going to pull your acetabulum. Remember earlier, before the break, I said, Bobby, what does that obturator do? Does it pull more on the femur or pull more on the acetabulum? I was making a big deal out of it. What's going to come back, we're going to talk about it. And she says, well, there's a lot more green on this A bone. The obturator is an A bone. It pulls the A on the femur. This glute does not pull the A on the femur because this glute doesn't even come close to this acetabulum. Remember where the glute came from? Here, here, and here. It doesn't even attach to this part of the bone. So what's pulling this A on that femur? What's pulling the A on the femur? Obturator. Make a mental note of that. The obturator pulls that A on that femur. So the first piton says external rotation. External rotation of an F on an A and external rotation of an A on an F means that I'm going to have to shift my body weight now, at least consider shifting my body weight, have to consider it, hopefully you'll do it, to the opposite side. That's your first piton. You pound the piton in, we're going to call it a glute max piton. You're going to use it to shift you over to the left side with rotation forces, F on A on F. Now we're going to go to the second piton. The second piton says, I'm going to pull A onto F, and I'm going to pull F into A. I'm going to pull A onto F, and that would be the glute med and min. On the right side, I want my glute med and min to pull A on F. It's going to pull the A down on the F. We call that hip abduction. Hip I don't want hip adduction on my right side. I want, Pat, hip abduction on my right side. I want to pull A onto F with my right glute med and my right glute min via attachments to the greater and lesser trochanter where you colored, with the innominate bones serving as a direct attachment to each other. So they come from the med and min come up and they go to the innominate, but there's a med and a min for some security to pull the acetabulum onto that femur. Abduct that femur. Abduct. This is different than this. That's the same. This is abduction of the femur, same muscle. This is abduction of the innominate, same muscle. But it is different. It's different because here I'm moving my acetabulum that's going to shift me over to the left side. Here I don't have to absolutely shift doing this. I can lift up my femur and not shift. But if I do this, I have to shift. Katie, here I don't have to shift. But if I do this, I have to shift. If this bone does not move, I have to shift. But if this bone moves, this bone didn't have to shift. Does that make sense? So that's why when you pull the med and min pulls the A on the F, you're now shifting into the left. The iliacus pulls the F into the A. The iliacus is pulling the F, watch me everybody, into the A as you do it. Because this bone is being pulled into adduction. This bone's being pulled into adduction with the muscle on the other side. Remember I said, remember this, folks? What's on the other side of the glute med and min? You all said what? Iliacus. One is an A on F muscle, and one is a F on A muscle. This is just sesamoid bone. So you can't do A on F and A on F, or F on A and F on A, if both of them are working correctly. That's your second piton. Why are these two pitons in there? Because that's the desirable real estate to keep you shifting from side to side. We could easily write up there, you might want to do that, desirable real estate for acetabular hold control in the frontal plane. Okay, we could then complement that by saying desirable real estate for acetabular hold control for transverse rotation. We could do that as well. But we really also should remember that if you do what I just said with those two pitons, my need for you, Carl, goes way down. I don't really have to absolutely go after my left hamstring right away, because now I'm going to demand that left hamstring work by these two pitons. I'm going to demand it because I'm pushing you over there. Now, if your hamstring doesn't kick in, we got a problem. What's going to happen if the hamstring doesn't kick in? Both those pitons could what? Come out, both of them. Because the next step you take on that left leg, if you don't have that hamstring, pop, one of those pitons is going to go. If you pop them both, you're right back over to the right side and pop off, start all over again. What keeps the pitons in the rock then? Carl, you know the answer.
Hamstrings.
You're going to hope that the desirable real estate that I'm going to get, that's going to be considered, can we write the next thing down? Desirable treatment for the acetabular hold control. Just write treatment. Desirable treatment requires those four muscles. It didn't say desirable real estate for repositioning. What would be the desirable muscle for repositioning, Carl?
Hamstring.
I'm going to miss you tomorrow. Hamstring. On which side?
Left.
Therefore, we're going to get left hamstring, right hold control to give you left AFIR. Are there any questions about that? I love talking about this. It's so much fun. I miss it. I really do, Jen. Does this make sense to everybody? Got that? That's what we want. We want right pushers. Right pushers. Okay, we want left drivers, but we got to get you over there to that left side with that right glute max. Then we got one last piton. Do you see it? Adductors and gravity. Adductors and gravity. Which side do we need to now? What do we want? Left adductors and left gravity. Left, we don't have to worry about gravity. Gravity will take care of itself. That's why it's the very last piton. Is gravity a bad thing or a good thing then? It's a great thing. Gosh, we want gravity. Take it. Guys, I don't know if you're using your gravity every day, but I am. I want gravity on my left side. Give it to me. Give me the big G. I want it. Give it to me. I want my knee to bend. I want to be able to reach. I want gravity over here. I want to feel gravity over here. I want to feel those adductors work while I'm over there on that side. So if you keep your last piton alive, gravity and adduction, the first two pitons will never, ever have to work hard. Do you follow me? You're never going to break them out. They're never going to pop out of that rock. But if you lose 5 and 6, and then you lose 3 and 4, and then you lose 1 and 2, you're going to look at like that little girl that I showed you with all that rotation. She lost all her external rotators. She has no pitons left. She has no ability to get her body over to which side, Katie? The left side. Thank you. She lost them. Her right femur was completely internally rotated. That one picture of that lady with all that internal rotation on the right side. I know she lost her pitons. She doesn't have anything holding her up. So, Carl, I could give her a left hamstring program, but I would never be able to treat her until I did something Chad said. I got to complement that left hamstring with the right glute max for hold control, because if I don't have hold control on that right side, to get her to shift over to that left side, to approximate my right femur, approximate it, so I can get over my left femur to approximate it, versus laying on it, I'm probably never going to get her. So I'm going to have to give her a right glute max program. Now,
I have a question.
Yeah.
I don't know if this is going to come out right.
It's going to come out fine.
I spent a lot.
I just want to hug you for a question.
Well, we spent a lot of time showing different exercises for glute max, glute medius, iliac adductors, but we don't specifically say obturator.
Right.
Like how to
Correct.
facilitate that muscle to the best degree. So is that just kind of go along? Is this being worked while we're working the glute max?
It's a great question, Jen. She's saying, I see a lot of right glute max exercises. I see a lot of left inner thigh muscles on the left side called ischocondylar adductor work. I see a lot of left glute med and min, but I really don't see much for the obturators. I really don't see much for the piriformis. But if you go in the back of your manual, you'll see a little bit more of those with regards to the scenarios that we're giving you. But underlying every glute max activity, you're getting some obturator. Okay, and underlying every single activity that where you're going to talk about upright activity, where you have a right FAER activity going on, that's obturator. Okay, hold control is really important. Hold control is not this. That's just hanging.
Right.
We have activities that we're going to actually take our right leg and generate push and extension on the left, like retro stair climbing for right glute max, or retro walking, okay, where you have to extend your left hip with right AFER and FAER, depending upon the technique you choose. But you're right, we don't isolate just obturators. The reason we're into obturator-itis right now is because I want everybody to appreciate that the obturator has to have a 90-90 position to it for you to have an effective way to externally rotate your acetabulum on your femur. Because if it goes into the Platte River and it's flat, you can't externally rotate your femurs, and your back is now going to attempt to do it for you. You can do all the work you want with that AF and FAER, but it isn't going to matter because you don't have the 90-90 waterfall. On the right side, you have a 90-90 waterfall, but that muscle, as you read on page 18, is long and what? Weak. To get it strong, you got to get it over on the left side. To get over to the left side, we got to use the obturator that's in a better position on the right side to be able to, for that right side to become now short and strong. So it's a good way to discuss what's going on with frontal and transverse plane by looking at the obturator. We can look a little bit at the gemelli and the quadratus femoris muscle. We could look at the piriformis. But technically speaking, the best one is the one you colored green because it covers the entire innominate on the inside along with the iliacus. It's a good conversation. We don't talk, I asked Jen at break. Let me tell you what I asked Jen at break. Jen, do you want me to get into the iliacus today? Because she knows we're going to cover the iliacus in advanced integration. When does the iliacus become an internal rotator? What does it do for acetabular femoral work? Well, we cover that when we take pelvis, we integrate it all. So she said, no, hold off on the iliacus. Just stay with the obturator. That's what we're doing. So underneath that, you've got other things going on. We're just using it to explain functional activity of A on F, F on A, and when it happens. And probably, I think it's a really good thing to look at, because if you look at it from the structural standpoint, all your external rotation on your right side has to have that 90-90 sacrus spinous hold for that piriformis and obturator to go underneath. If you lose it and you pop up in the air, you're in a bilateral chain problem. You still got to go after the same hold control on the right side to get you over to the left. No matter who you are, you want to start there. Hopefully, once you do a 90-90 hemi-bridge on the left side and get your hamstring, this discussion we're having will take place automatically. Not always a guarantee. Treatment really does reflect what's on page 30. That's the treatment program you want to look at. Karina, we're going to give you exercises for each one of those muscles, techniques for each one of those muscles that follow that algorithm. But I got to explain to you why. There's two different processes, when you have pathology and when you don't have pathology. But when I get Jen into glute max activity on the right side, that treatment of that glute max is going to reflect that activity. Jen, I will go over right glute max and left glute med. These are your top anti-gravitational external rotators on page 31. So, Karina, what would be the top muscles I want both sides, not left or right, both sides? What do I want to use to make you sense gravity? Glute max. What's another one? Bicep femoris. What's another one? Man, those three, we just hit all three. Thank you for your help. All three. All three give you internal sensory input of where you are on the ground. All three are big anti-gravitational muscles. Is one more important than the other one? I have no idea. There's no research, Chad, that'll tell you one's more important than the other one. The top anti-gravitational internal rotators, these are them. These are nothing but goodness. You notice TFL isn't up there? You notice vastus lateralis is down up there? The most powerful positional ERs that you got glute maxes that can be FA or AF, obturators that can be FA or AF, psoases that can be FA or AF. Those are the most powerful external rotators. And it might shock you that the psoas is up there. The psoas is not a bad muscle. The psoas muscle is not a bad muscle, especially in open swing. It's clearance. It's not a bad muscle. It's powerful when it comes to external rotation and position. The most powerful positional IR muscles, TFL, it's not a bad muscle. Anterior, it's F on A, anterior glute med, AF, FA, adductor magnus, circle. Those are all. The anterior glute med in men will do both. The TFL will move your femur on an acetabulum, especially if your acetabulum is already in a forward position. And the adductor magnus will move your acetabular into an internal rotation position, especially if the acetabulum is already there. So you want to use these muscles when you are in a state of neutrality. You don't want to be using these muscles if you're already in a state of internal rotation or internal orientation. I'll back up. These are most powerful position IR muscles when you can get into a state of neutrality. This is what you want. Those are the most powerful positional ER muscles, provided you can get in a state of neutrality. But if you're in a state of IR, in other words, you're oriented there, they're not very powerful. If you're oriented in a state of IR, those ER muscles are not very powerful. But I just want to make sure there's a slide in the manual that says these are not bad muscles. If the world was exactly like Shirley Sarman said, God love her, I love it. You're right, Mike. She would look at strategies based on the fact that you can move into IR or ER. You can do it. No limitations, no strategy to move. No strategy to move is needed. Then you would use these muscles as the powerful external rotators for dealing with gravity and for dealing with power. When you want a football player to move, you want glute max, obturator, and psoas to move you. When you want internal rotation, when you want somebody to drive a tennis racket on an internally rotated body, you want TFL kicking in, you want anterior glute med kicking in, and you want adductor magnus, ischiocondyle, all kicking in. That's good, provided you can come right back out of it, Chad. That's all I'm saying. These are muscles that we shouldn't drop off our cortex. These are good muscles. Does that make sense, everybody? These are the desirable ones. We already covered this, vastus lateralis, so I'm going to move on. This is a picture of a person who has a vastus lateralis that's overdeveloped on the right side because they can't shift over the left side. And it's always, this picture always is nice because they're just flabby over here. Everything's just saggy, and there's nothing really strong on that left side. It's small. Look at that little quad here, and look at this quad over here. This person on the right side is using something on the right side for internal rotation a lot. Adductors and vastus lateralis. Here's another one of those animals that constantly, when you see this picture, everybody, I hope you understand that this individual is weight-bearing more on the right side. That is a right stance-oriented individual. Look at that huge VL on the left side. This leg is an abductor leg. This is an adductor leg. This VMO is going to be, this all is stronger than this. This is powerful over here. Does that make sense? This is a shifter to the left. They're constantly shifting over to the right because they can't shift over to the left. Can I just do a little algorithm? We'll just start off here a little bit. Let's do some pitons here. What's the butt muscle? And you can see it from here. What does he need over here, guys? He needs a powerful glute max, a powerful glute max. A powerful glute max to pull a femur into an acetabulum, yes, and a powerful glute max to move an acetabulum on a femur, external rotation-wise. What else does he need on this right side? What does he need that's got to have a little more power to it, besides the right glute max? Somebody think a little bit about this. We'll come back to it. What does he need on the left side, Chad? He needs a left what? Adductor, glute med, glute min, okay, hamstring, okay? That should give it away. What does he need on the right side? If I said hamstring on the left, what should he need on the right? Say it loud.
Quad.
Thank you, I want to hug her. This guy can't use his quads correctly on the right side. He doesn't need to. He doesn't need to pull him. He's already there. Do you follow me? He doesn't need a quad to push. I mean, he's already there. He's hopping off that right side. He needs to learn how to use a quad as he's going in transition over to the left side. His quad is underdeveloped on the right side. He needs quadricep work on the right side. It's like that girl I showed you this morning with the protonic device on the left side. They need quads on the right side, but you're never going to get a quad to work on the right side if the quadricep muscle is already in a state of push-off. It's in extension. They've got hamstring. They don't need it. They're locking out. They don't need it. There's too much rotational band on the quad, and they can develop, Chad, you've seen, they can develop VL activity on the right side as well, but for a different reason. So the answer is quad. Thank you, Karina. This is a person that has a hyperactive TFL bilaterally, previous sports hernia surgery, complaints of low back pain, bilateral positive extension drop tests, and uses his TFL for AFIR control during stance phases of gait. Both legs would hang in the air like that. He is down 40 degrees of hip extension on both sides. He doesn't have his 28 degrees of hip extension, plus he's got 20 degrees that he's lacking even in this position. He can't even get his femur to the mat, Lydia, let alone another 20 degrees past that. So this guy's going to have overdeveloped VLs, underdeveloped glute maxes. This is a story of a lady who's a PT in Kansas. Years ago, she came in and she goes, you know, Ron, they want to cut my IT band. She got to me because she read something about protonics, and she drove up. Sweetest lady in the world, but she's got some wider hips, and she's got a very, very narrow torso. And look at the strength. Look at the strength of her VL and her lateral side of her leg. This is her left leg, and she cannot adduct. We're going to look at this on each and every one of you here in a few minutes. I'm shoving her hip forward to line her up, and she cannot adduct. Now, the reason she can't adduct is because, one, the acetabular wall will not let that neck of that femur adduct. We'll go over that here in a minute with those tests. Two, when I bring her back into this position, she's starting to hyperextend her back because I'm trying to get her to line up. Three, she neurologically doesn't even understand how to internally rotate this leg. So if I would take her leg and internally rotate her femur, she might be able to adduct, Dallas. She might be able to. But when we learn this test, this test, where we take the leg, this Ober's test, and bring it back and keep the foot and the thigh parallel with the floor. We don't like it to roll in or roll out. We parallel that tibia to the floor and bring it back in that state of ER to her, because she technically is in a state of what? Internal rotation or orientation. When I ER that leg by putting that tibia parallel with the surface that I'm working with, the horizontal surface of that mat now is got to match the parallelism of her tibia. So I'm taking the tibia and matching the horizontal platform that she's laying on, and I'm bringing it back, and I start to adduct it down. She's locked. It's bone on bone. If I would internally rotate that femur to match the orientation of her acetabulum, she may go into adduction. But she would have to do that with every step she would take. And thus she's getting IT band tightness because she's overworking her TFL and her outside of her leg, her abductors, to hold herself up when she picks up her right leg. Because technically, Chad, she cannot do what on that side? Adduct. She can't get her acetabulum to cover that femur to adduct. So I pull her back and she's positively hanging in the air. Now we put her on her side. This is called a 90-90 hemi-bridge-like position on her side. And I put a little rolled up towel under her to help her distract, to help her pull apart a little bit, to get her femur to move out a little bit, as I asked her to pull her left leg back, and she's pointing her finger on the posterior capsule. She's feeling a stretch in her posterior capsule, Lydia, as she does this. I'm guiding her with her femur inwardly oriented because of this rolled up towel. I'm guiding her into adduction, internal rotation. And here's the kicker: acetabular femoral internal rotation. I'm guiding her into right AF ER and left AF IR. And I'm asking her every time she takes a breath of air in, as she breathes in, I'm holding her down and I want her to squeeze a little bit so she can efface that posterior capsule, efface that inferior outlet, if you will. Everything's got to open up. Inlet and outlet's got to open up on that left side. There's the ball. I put a ball between her legs now, and I'm asking her to shift forward and back. She goes forward and back. And when I get her all the way back, I have her take another breath of air in as I internally rotate that femur for her. Every time she breathes in and she internally rotates that femur, I'm getting more and more acetabular femoral what? Internal rotation. And her back is staying as round as I can keep it. And she's working, and we're working together, and it's not killing her at all. She's feeling a little pull back here, a little pinch from the front because she's using that ischiocondylar adductor to do so. Then I ask her, could you do me a favor? Could you put your knee on this towel, put this bolster underneath that femur, and now could you push that femur into my finger. And yes, she will use her VL, but she's also using her ischiocondylar adductor for the first time. And she's figuring out how to get her glute med and glute min anterior fiber kick in with what hamstring, medial or lateral. Folks, look at this. I've got all of the good internal rotators. I've got her TFL out of the picture. I've got the medial hamstring kicking in, the ischiocondylar adductor kicking in. I've got a lot of anterior glute med and min kicking in, all as she's trying to breathe in by pushing into my finger. And then I ask her, let's take it away, and she adducts that beautiful leg. And look how wide her pelvis is. She can adduct that leg for the first time. Now, the only reason she could do that is because I inhibited all of those IRs on the contralateral side. And I facilitated ER activity on the contralateral side. I facilitated hold control because during this whole thing, every time you see a picture, her right foot is giving me hold control on the right side. Someone tell me, how am I getting hold control on that right side? Look at all these pictures. How am I getting hold control on the right side? She's pushing that right foot what? Into that wall. She's using that right wall as a hold controller, as a stabilizer, so she can give me better rotation with that left side. What muscles am I using on the right side for external rotation? Let's go over them. Am I using an obturator? Yes. Am I using a triosseous muscle called the piriformis? Yes. Am I using an iliacus? Yes. Am I using a glute max? Yes. Am I using lateral hamstrings? Yes. Am I using posterior glute med and min? Yes. What are all those muscles add up to? External rotation on that right side. I could go back to my piton, and I'm following my piton right now. I've got hold control. As she's moving that hole, stabilizing that right side, I'm getting her now to shift over to which side? The left side. I'm not using that hole for more AFIR with lengthened ER muscle. I'm getting more AFIR on the left side with shortened Shirley Sarman ER muscle. Does that make sense? On the right side. This is a young man who comes in, and I'm just showing some good pictures of TFL overuse. Doesn't have enough extension on the left side. It's an IT band waiting to be cut, waiting to be stretched out, cupped, whatever you want to do. Or not young man, it's a young lady, I'm sorry. But it's very, very tight on the side, very tight, all the way down. I would do the very same thing. Now, I love this picture, and I love it for a couple reasons. Number one is, you cannot get this guy to shut off. This is the rectus femoris muscle. I could walk up to this lady, let's see who in the room can get this. I could walk up to this lady, and I could do something, I could ask her to facilitate something on the left side, and I'm going to take Carl out of the picture. I'm not going to use the word hamstring. I could put my thigh on her left leg, and I could ask her to do what? When she tries to bring this knee up into external rotation, what would I ask her to simultaneously do with her left side? What? I could, but I'm not going to use that. I'm not going to use her semi-tendy, semi-memby. I'm not going to have her do any hamstring work on the left side.
Push her hip down.
Thank you. Chad, I could ask her to move her entire body down that mat. I could put my thigh underneath that left foot, and when you breathe in, and I would ask her to bend her knee, and when you breathe in, I want you to fire your quad, fire your hamstring, co-contract everything, and feel what? What was the one thing that was the third piton? What was the third piton? Go back to your manual. Tell me somebody the third piton in your manual. And what? Adductors and what? Gravity. I'm going to skip everything above number 6 in your handout. And I'm going to say, all I want you to do, Chad, is tell me, do you feel pressure coming up on that left foot? That's it. What would happen to that right rectus femoris muscle? It would shut down. Because she's using her right rectus femoris muscle to pull her pelvis forward on the right side to deal with gravity that's no longer there. I would say push down on my left side, For whole control on which side, Jed? My left side. I'm going to go on the left side, give you whole control on the left side, so you can externally rotate your right side, which will help you shift your hip back to the left side, which would decrease that right rectus femoris activity. Do you follow me? This is a picture. I love this picture. This is not of a TFL. This is a right overused hip flexor because she doesn't know how to get enough hip extension on which side. Now, the easy answer would be, I could get her hamstring kick on the left side, but I don't have her in a 90-90 position on the left side. Her leg is straight. So Chad, you win the car, I'd move her down here, I'd put my thigh on her left foot, her right knee is bent, I'd say do some external rotation. While you're doing the external rotation, Chad, could you please push into my left thigh? As I push up on her left thigh, her right rectus will drop off so easily because now she's getting what on the left side? Extension. She's not trying to find extension anymore. She's got it. She knows where she's at. Which hole did I control doing that? The left side. I've got left hole control so she can operate her right side without trying to overuse her right side. She'll shift better to the left side. It's just a great picture of a rectus. I'll have her externally rotate, and look at this, guys. Which foot did she just pick up? Which piton did she just pick up? You said it, number 5. What? Adductors. But I didn't do it in a 90-90 position. I shut this off, goodbye, the minute she externally rotated and kicked in that adductor. Goodbye. Right AFER followed by left FAIR. And if I really was smart, I put a little resistance through that foot. Why don't we get her upright and figure out how to do that down the road? A little AFER on the right, a little FAIR on the left. That's not good AFIR on the left. It's FAIR on the left. All I had her do, Bobby, was internally rotate that femur. That's it. But she's getting AFIR on the left because she's pushing her left hip down to get that FAIR because I FAER'd on the right. But I could have complemented it by giving her a little bit of gravitational support under that left foot. I could have done that. So, on page 32, to summarize all this, which pelvis, myokinematic influence of the pelvis and femur, which pelvis and femoral rotators are inactive and active, long or short? You have page 17 and 18 in your manual to answer those questions. Okay? I would ask you to look at that again, 17 and 18. What femoral rotation is also a pelvic mover and stabilizer? What femoral rotation is also a pelvic mover and stabilizer? And again, I put the asterisk up there because if you think about that, the pelvic mover and stabilizer is going to be right obturator, right glute, right external rotation, right hole control. It's also going to affect your pelvis. 1/3 of the hip flexion movement is the consequence of pelvis posterior rotation and or back extension. This rotation always occurs within the first 8 degrees of hip flexion. Therefore, it is important to have working AF extensors and external rotators before you do anything with rotation of the femur. Richard Bohannon. Beginning of the pathomyokinematic pelvis. Beginning of a pathomyokinematic pelvis program. In other words, a program where you have pathological issues. You may see long inactive bicep femoris, long head bicep femoris on the left side. This is the beginning of pathomechanics. And I do want to go over this slow. I'm going to show you the beginning of pathomechanics. And Katie, I hate to do this, but can I just show everybody the beginning of pathomechanics? So beginning of pathomechanics, long inactive bicep femoris musculature. Come on up here, Katie. Katie's had 3 children. And if you can watch Katie walk towards the camera, just walk towards Don. And walk away from the camera towards me. Do you see in the camera how she's moving to the right? For those people who can see her. Can you see her at all? Jen, would you look at Don's camera? Can you make sure she sees it? Can you see it? Right, right, right. Do we need more? Okay. So she's a beautiful left AIC patterned individual. Long patterned individual. I've known her for quite a while. She's had 3 children. She looks great. Lay back on your back. Do you mind if I share all that, Katie?
No, I don't
It's too
know.
late. It's already on there. This is the beginning of what I would call pathomyokinematics of the pelvis. This is the beginning. Why is that the beginning? Well, it's not bad. Why is it the beginning, Chad? Because she's dropping off what? A little bit of what? Hamstring. It's not bad, but it's the beginning. We're going to have a lab. We're going to see if anybody in here has more than that for hip what? Flexion. So I'm just showing the beginning. Next one says long inactive ischiocondylar adductors on the left. Let's lay her on the right side. And I haven't checked this, right, Katie? I've not checked this. I'll do all the work, Katie. I'll do all the work. Okay, that's the beginning. Why is that the beginning? A lot of abduction. Let's check the other side. Put your head down over here. Whoa, Katie. Do you think there's a difference between those two sides? Would you agree?
Yeah.
That's the beginning. Long and active IC adductors on the left side, which is why she could abduct to the ceiling. On the left side, she's got maybe, what, 15, 20 degrees? That's the beginning. What's the next one say? Long, weak, inferior glute max on the right side. Sit on up, sit on up. Let's check her glute max on the right side. Okay, Katie, this is external rotation strength on the right side. Hold it right there, you got it? Mm-hmm. That's your right side. Hold it hard, Katie, hold it. Katie, there it is. What do you want to give yourself? 3 plus?
3.
3. Here's the left side. Hold it, Katie. Got it? Katie, do you see the beginning?
Yep.
What do you want to grade that one?
4.
That's the beginning of a pathological hip. That's just the beginning. Have a seat. So those are the beginning stages of a left AIC pathological problem. We don't know. I just took 3 things, Chad showed you 3 things. Katie, have I ever checked that before? Possibly when you were what?
Ago.
Hundreds of years ago. Years ago. The most important thing, the hip is IRER, which activates receptors of the posterior and anterior capsule. It's all about receptors. Abduction and adduction is important because these receptors, when they're activated, will help you understand the position of the capsule that you're in. Less than 3% of the capsular receptors are found to be excited by flexion extension of the hip. More importantly, underline this, we need our adductors and abductors to work as FA and AF rotators, because that's when your reception of where you're rotating and are go way up, instead of musculature that work as abductors and adductors in their frontal plane. So we want to maximize our frontal plane to get our ability to understand our transverse plane. The minute I give Katie the ability to abduct and adduct like she should on both sides, her receptivity to transverse rotation, Lydia, is going to go way up. She may not really be a grade 3 on her right side for her glute max. Wouldn't it be amazing if she gave us more than a 3, like a 4 or 5 in her glute max, as soon as she could adduct her left leg and abduct the right? Wouldn't that be cool? If her strength and their rotation went way up because of myokinematic receptivity to where your capsule receptors are saying, I got you now, baby, I know where you're at. Prior to that time, you're in a state, a position where you can't activate that transverse plane. If you do not have the frontal plane, your ability to sense what strength you need to have for a transverse plane is gone, because your brain isn't on the transverse plane. It's on compensation for something you can't do in the frontal plane. She had a grade 3, 3 minus, 3 plus on the right side. Wouldn't it be interesting to see what you do after we reposition her and give her the ability to actually translate into the frontal plane? And we'll go back and we'll check that strength, Katie. So that's also in your manual, number 5. F8 adductors and internal rotators lengthen the obturator internus. F8 adductors and internal rotators lengthen the obturator internus. It puts you, it lengthens you, it makes you excited. It activates it. So it's a good thing. And you get more of that into the pelvis course. Lifts it. Internal rotators of the FA joint lift, there it is, lifts the levator and pelvic floor and stabilizes the low back. Circle number 7 2 to 3 times. Because see, Katie, the next course you might want to think about is the pelvic floor course. Because it lifts you. It gives you a diaphragm fulcrum. It gives you power. 3 children. You got power there now. So we want to lift you. We want the obturator to be a lifter. We want the obturator to be, therefore, a pusher. A lifter that lifts the pelvic floor pushes you down. Pelvic floor comes up, legs go down. It's all respiratory at that point. And that's kind of an overview on page 32. Okay. The upper half, I'm going to summarize this real quickly. The upper half of the pelvic musculature are listed on page 32, and the lower half are listed also on page 32. Circle the word glute max influences both upper and lower pelvic floor function because of its attachment to the sacrum. But this obturator, levator ani, coccygeus, pubicoccygeus, and adductors are all lower half pelvic floor musculature that in this course we're doing something about. So that these things, which is really your anterior chain, your TFL, your psoas, all the way up through the upper half, can actually be placed in the right position to work. And number 1, I want you to understand, piriformis syndrome is an indicator that these other muscles are not in the right position. When you're working your piriformis to death because you don't have a glute max that's working correctly, you don't have to worry about the piriformis. It's a message, Chad. It's saying those muscles underneath me are not in the right what, Chad? Position. The piriformis is a beautiful muscle if it's working in the right position. If you get piriformis syndrome or sciatica, which is in your manual, the back, Jen asked you guys to write a question tomorrow or 2. But go tonight and just take a minute and go back to your appendix and read about piriformis syndrome. You have a left side and you have a right side. Left piriformis, right piriformis syndromes. What would you do differently to treat those? Ask that question and maybe go back and look at that so we can generate some discussion. I will go over it if you don't, but I just want you to understand that I would take the opportunity and say, well, how would you treat a piriformis syndrome on the left side versus the one on the right side? While we have you, why don't we look at that? Okay. These are the tests. We're going to go ahead, and we're right on the hour, a little bit over, and I'm going to take abduction drop test, extension drop test, straight leg raise test, trunk rotation, and we'll look at femoral rotation range, and then the other 2 or 3 we'll talk about tomorrow. And Katie, this is where you're going to help me read. You'll read, and Lydia is going to be my subject. So you'll read, I'll demonstrate, and then we'll have about 20 minutes or so, 30 minutes to do that before you go home. That's where we're at today, okay? Is that good, Jen? So, got anything? You're smiling at me. Ready? You know where we're at? Got it? Adduction, first one's the adduction drop test on page what? Page 34. Could you come on up, Lydia? All right. Here we go. Lydia, would you mind taking off? You have the shorts on. Why don't you take those slacks off? Okay, why don't you go ahead and get started. What are we going to do with the patient? Position or what?
Position in side lying with the lower leg and hip flex to 90 degrees.
Okay, we'll start off with her right side. Face the camera, okay? We'll start with the right side. We'll face the camera. Okay, check. She's in 90 degrees. Got her 90 degrees. Now what?
Passively flex, abduct, and extend the hip to neutral while maintaining 90 degrees knee flexion.
Okay, so I don't want her knee to extend. I'm going to take her leg, and I'm going to passively move. I'm going to passively flex and abduct and extend the leg. And this is considered neutral. And I got my hand on her pelvis, and I have my other hand on her tibia, and I'm lifting, I'm flexing, abducting, and then what am I going to do? Extend. I'm going to do it again, everybody. I'm going to flex, I'm going to abduct, and I'm going to bring it back, and I'm going to rest it. What am I going to do now?
Passively stabilize the pelvis from falling backward and allowing femoral internal rotation to occur.
Okay, keep going.
Make sure the top innominate is positioned directly over the bottom innominate so the frontal plane starting position does not give any false positives.
So I don't want this, I don't want this, I don't want that, I don't want that. If I hurt you, let me know. I got it directly over and I'm securing her, right, Lydia? Can you feel that? And then what? Is that it? And my lower. And she's resting her femur is resting on that lower rim of that acetabulum. She's resting there. If I internally rotate her, she'll drop easier than if I externally rotate her. She's resting there. My theory at this point is this pelvis probably is anteriorly what? Positioned. That would be a theory until we go through all the tests. But so far it looks like she's in a positive, that would be considered a positive test. Jen, please look over my shoulder because I can't see that. Is there anything you want to add? Okay, next slide. What does it say here?
A positive test is indicated by a restriction from the anterior inferior acetabular labral rim, transverse ligament, and piriformis muscle, or impact of the posterior inferior femoral neck on posterior inferior rim of acetabulum that does not allow the femur to adduct, possibly secondary to an anterior rotated forward hemipelvis, the AIC.
Of the anterior chain. I basically said in layman way, she said it much better than I did. So that's a compliment what I said earlier. Okay, let's go to the next slide. Okay, positive and negative. Everybody see that? So if that's a positive negative, what is this? What is that? That's a positive test. Let's look at the other side, Lydia. Put your head down here. I'm going to stabilize. I don't want to hurt you here if I do. I'm going to flex, abduct, extend, and it's also positive on this side. Okay? She's positive over here too. So we have two tests that are positive, one on each side. Next slide. Go ahead.
Position supine, hip and knees flexed to chest.
Stay right here. Okay, position supine. Lay on your back. Keep going. Slide all the way down here.
Passively lower one leg over the edge of the table while keeping the other leg close to the chest. The back should be flat.
Scoot down here for me, Olivia. Okay, so I'm going to take both of her legs up, and what I do on this test, Katie, is I try just to find a good position for the low back to rest on the mat. I don't want a lot of this, Papa Bear, and I don't want this, but I want a Mama Bear, right about in there. Okay? Go ahead, what next?
Do not allow hip abduction to occur past 0 degrees on the tested extremity while passively dropping the FA joint into extension.
So don't let this leg, if I start the left, roll out to the side. Don't let it abduct. Stay right lined up with the body, keeping in mind where this leg is with respect to the shoulder and the trunk. Go ahead.
Positive test is the lower extremity, usually the left, is restricted because of the forward orientation of the tested side compared to the other. If both femurs do not approach the edge of the mat or table the patient is tested on, the nominates are rotated forward bilaterally and the psoas muscles are on slack. Placing the femur in neutral is actually placing the femur in external rotation. This tightens the TFL and VL, restricting hip extension.
Okay. Katie, you're going to be a good model for that one, so I'll use you in a minute. What is this? Go to the next slide for me, Matt. Okay. The previous slide will tell you whether or not she clicks in and out of a socket. If she clicks and you hear a click, she's bypassing a rim. Can you go back to the previous slide, Matt? Rotary components seen with limitations in hip extension on one side. The femur in this case will not approach the supportive surface without the femoral internal rotation and or through luxation. So in her body, go to the next slide, she's going to give me a test that looks what, everybody? Negative. Should that test be negative or positive right now? Should be positive because she couldn't, in the other test position, bring her leg all the way back. So I know she slipped out of that socket. I know she bypassed that hip. Katie, I'll use you with an intact pelvis here in a minute. So that's a negative test, which is an indicator that she probably has got a little pathology of that left hip, okay? If I go up to the other side, and I do this side, she also is going down way too easily. The reason I wanted both of these clients, and you're gonna stand up, and Katie, you're gonna come up, is because I just wanna make sure you understand that that is a negative, don't go too far, Lydia, that's a negative test on Lydia, but it shouldn't be negative. Lay down. We're going to do the same test on this lady. I did the very same thing. I supported her. I'm guiding her down. And as I guide her down, that is what that test should have looked like on that lady. If I internally rotate this leg, it's going to go down a little easier, Katie. But if I don't internally rotate and I keep it lined up, it's going to stay more flexed because of the orientation of that acetabulum to this femur. If I match the femur to the acetabular orientation, she would go down. But I'm asking you to do the test the way we were taught in school to do it. That's a positive test. Does that make sense to everybody? So I'm using these two women to teach you what a negative test would look like and a positive test would look like. And both of them have anteriorly rotated pelvises, at least on the left side. This is her right side. That's a lot more easy to bring down. In fact, she's all the way down. That's a negative test, reflecting a neutral position on which side? The right side. Katie, you're doing all the job here today, reading and demonstrating. We're going to go to the next test, okay?
Flip her on her side and show an adduction drop test.
For the
For
camera.
Katie, the adduction drop test.
On which side would you like, Jen?
Go ahead and do both sides,
Okay,
just so
then
they
you're
can see the
left side.
correlation of the extension drop test.
So here's her adduction drop test on the right side. Here's her adduction drop test on the left side. I can't get her back without her extending her back, so I know she's not going to go down. But we already knew that with the abduction and adduction passive raise test a few minutes ago. She couldn't abduct on which side? The right. Okay? Is that okay? Okay. Katie, you're going to keep reading. You're doing such a good job. Lydia, you're going to come up here, and Matt's going to go to the next test. It says straight leg raise. Katie, would you read that for us?
The patient lies in supine with the knees straight and not flexed. Passively take the patient's leg into flexion while securing full knee extension. Stop moving the leg at the point where the opposite leg begins to move toward the ceiling passively, or when the leg has reached a point where the tension at the back of the hip and leg is noted and limits comfortable movement.
Sounds great. So basically, you're just going to lay there, Lydia. I'm going to take this left leg. I'm going to start going up in the air. And Lydia stops right about there. Somewhere in there, Lydia. Would you agree? Give or take a few degrees. Let's call that, Jen, what do you want to call it? 50, 60, 45? Okay, 70 degrees. Here's the right side. They're about the same. Would you agree? Both sides are about the same. Katie, we already looked at yours. Yours went way past 90. I mean, went past 90. So technically speaking, she has hamstrings, but it looks like, and that I'm kind of glad they're a little bit indicative of a pelvis that's too far forward on both sides, however, which is what she's demonstrating. However, she's easily dropping all the way over the edge of the bed. So where's her pathology right now? Is it her hamstrings? No. Where could be her pathology? Say it loud.
Hamstring.
It could be her hamstrings. She needs more hamstrings overall. Your pathology is, I got to get her on a program. Remember this tomorrow, Jen. Tomorrow there's this like case A, case B. People who have pelvises that are in an anteriorly rotated position and their pathology in the front of their hip is not keeping them in the right state because they've now compensated so well to come forward out of that socket by over what? On one side or both? Externally rotating, and she's doing a really good job of that right now. Her legs are externally rotated. Your situation, Katie, would not be this one. Your situation is your straight leg raise is a little too uncomfortable for me, especially on the left side. We want to get your hamstrings a little bit more what? Active. We could activate her hamstrings, but I'm not sure that would help Lydia without a program that's going to retrain her how to stay what? Internally rotating her femur when she puts weight on it. Because right now when she puts weight on it, it appears to us that she's overly what? Externally rotated with the compensatory effort that got her here today. I don't think I need to say anything more about straight leg raise, so let's go on. Okay? We've done all that. Okay, trunk rotation. Would you read that, Katie?
Position supine, knees flexed and together, feet flat. Passively rotate the legs to the trunk's resting state with one hand while stabilizing the trunk. A yardstick Yardstick may be used to measure.
Okay, so we're going to move her legs, and this is all kind of in your manual, so we're going to kind of move a little faster. I'm going to put my hands on her thorax, and my hand on her thorax, my other hand on her knee. And Lydia, I'm going to keep you solid here, and I'm going to gently guide her legs to the left. And wherever her leg, man, it's going for a long ways. This is a loose young lady. She's way over here. And if we take this yardstick and we measure her from the top, I'm going to drop that right leg. Can you bring it back up and help me a little bit? Okay. If we go ahead and go down again and she lets it go, just let it go. There. On this side, she has 16 inches between the top of the mat to the top of the knee that I have my hand rested on. This is called right trunk rotation. This is Dallas right trunk rotation. That would be 16. I'm going to take her gently over to the right side. This is called left trunk rotation. Left trunk rotation. On this side, she looks like a clean 14. So she has better left trunk rotation than she does right trunk rotation. Jen, what does that mean? Well, let's keep reading. What does that mean, if anything? Let's keep reading. Katie?
Positive tests, legs do not rotate in one direction as compared to the other. Trunk rotation is limited more to the right 2 degrees to probable left hip.
Secondary to probable.
To probable left hip anterior rotation and sacral-lumbar orientation of the spine to the right. Therefore, postural restoration should be initiated at the left lower extremity to address left mechanical instability and maintain proper restored pelvic femoral neuromechanics.
So, on a person who has right AFIR, a lot of right AFIR, and their spine is oriented to the right, and I take their legs to the left, you should see, can you click back, please? You should see trunk rotation limitation more to the right. So she should have more limitation here than she did here. Am I saying this right, Jen? Which she did. So it's not a lot, but Chad, you're going to see a lot with people who are really, really limited. She's kind of cheating a little bit. She's out of her joints a little bit, so it's not a great test. Katie, come on up here. We haven't looked at you yet, have we? Next slide. Next slide. So you should see limited trunk rotation to the right with her legs going to the left more so than the other way. And she did show that. You did show that, but it wasn't a lot. I have no idea what Katie has. I'm going to do the same thing. Here's going to the left. Whoa, she's got a lot. And here's going to the right. Whoa, she's got a lot. So Katie's much more loose in her torso than she is down here. So this torso is not limiting her. She's really maybe a little bit too what? Hypermobile. This test doesn't tell us anything because it's really loose. Just like her hamstrings were really what, Carl? Loose. So right now, she's not really tightened up like you are, Lydia. And honestly, when we do our lab, we're going to find somebody in this room that's going to be really cleaner than this when it comes to limitation, as you see up there. But she's really capable of moving both directions quite easily. So she probably has no brachial chain issues. Chad, I'm not going to get into that, but she has no, Jen, brachial issues, which we'll reserve for another course. Could you continue to read? Jen, do you want to say anything more about these two? All right, what's the last test like? Femoral rotation. I'm going to have you come on up here if you don't mind. Go ahead and read the next slide. There we go.
The patient is seated on the edge of a treatment table with knees bent at 90 degrees. This test is performed in the seated position versus prone to allow the hip ligamentous structure to be in the resting state. Using a goniometer, measure the patient's passive hip FA rotation on both the left and right side.
Nice job. Can we go to the next slide for me?
Want me to go?
Yeah, I do.
The most common goniometric findings of a left ASC oriented patient in the seated position usually reflect both osteokinematic and myokinematic influences. Therefore, in a non-pathologic compensatory
You're doing great.
pattern of a left AIC patient, Where osteokinematic issues exist, left FAIR will usually be decreased and right FAER will usually be decreased.
Before we go any further, and we just revised this manual, would anybody like to take a stab on that last paragraph? And even for the viewers at home watching this video, before we give the answer out, why don't you ask yourselves, why do you think that last paragraph is true? First of all, let's break it down. In a non-pathological compensatory pattern, well, in a non-pathological compensatory pattern, we're saying there could be some osseous or osteokinematic issues. And those issues will be seen by looking at internal rotation and external rotation. If left FAIR is usually decreased and right AFER is usually decreased, could someone tell me why that might happen, considering the position she's in when she's sitting on that mat? And the person who will show this to you is Katie. We're going to show you that. This is a good example of somebody who's a little pathologic. But before we go there, I want all of you just to ask yourself, why do you think the left FAIR would be decreased and the right AFER would be decreased on a normal human body with a left AIC pattern? Anybody want to take a stab at that? Katie, while they're thinking, can you come on up here and sit right here? Can you move down a little bit? Sit right here. So why will Katie show this? Why will Katie show less ER here and more ER here and less IR there and more IR here? Why?
Orientation.
Orientation of the pelvis. Okay. How does orientation affect that outcome? Take a stab.
If your pelvis is being driven one way, you're not walking at an angle all day long. Both femurs are going to orientate opposite.
So if her pelvis is orienting her spine to the right, like we talked about this morning, and I wanted to check her femurs based on the orientation of her pelvis and her spine, Chad, I would have to correctly redo this. I would have to take this leg and move it over here, and take this leg and move it over here. And now her IR and ER should be the same on both sides. Let's check. IR, IR, ER, ER. They're both about the same. But if I put her in the position that we do in school and we just get our goniometer out, this leg won't ER because there's a ledge here that she's going to pinch. And this leg can't IR because there's a ledge underneath that she's going to pinch. So she'll be limited more IR on the left and ER on the right because osseously she's over to one side when she's sitting there. Right AF IR, left AF ER. Did that make sense to everybody? And we don't reposition our patients to match what we think they're in. We're going to do that with everybody. We're going to sit them up, take the goniometer, and measure it. So I'm going to take the goniometer and I'm going to measure it. And then I'm going to show you this gal over here. And so I'm giving you the normal findings, and then I'm going to give you some findings that reflect some pathology. And then we'll stop, and we'll look at each other. We'll have the next 20, 30 minutes just to look at each other before we go home, because I want to know who you guys are for tomorrow. Was that helpful where we're at? So I'm going to check IR on both sides. Here's IR. She's sitting there. Here's IR on the left side. I'm going to give her 40 degrees. Here's ER on the left side. I'm going to give her 52 degrees. Here's ER on the right side. I'll do all the work, Katie. Katie, that's 30 degrees. You can feel it's less. And here's IR on the right side. Gosh, Katie. 63 degrees. So there's that pattern. We'll reposition her tomorrow. I don't know if anybody wrote that down. Did anybody write that down? Jen, could you write that down?
52,
52,
30, or 40.
30 degrees, and
And then
and 63, somewhere there. You're off, you're on. Now we're not going to worry about this one, we're just going to show you this one, okay? This one has full capability of extending both hips, but cannot adduct either one. You remember that? Thomas tests were negative. Adductor drop tests were both what? Positive. This is IR on the right side. I wouldn't even use the gun anymore. This is IR on the right side, 25, 30 degrees. This is IR on the left side. Why is that less than 40 degrees on both sides? Because she's out. She's externally rotated and she's out of her sockets. So when I try to internally rotate her, she can't corkscrew her femur in an acetabulum that's inwardly oriented those femurs. She's already out. I'd have to reposition both of them by taking her in to match, but she's out on both. Here's ER on both sides. Here's external rotation on both sides. Lots of external rotation on both sides because that's the orientation of her femur on both sides. Here's external rotation on this side. Lots of external rotation on both sides. Lots of external rotation on both sides. Limited internal rotation on both sides tell me that she's what, Chad? Effaced out. Does that make sense to everybody? Okay, let's hit another slide. Stay right where you're at. You want to read this? Would you do me a favor and read it?
Where osseous and capsular restrictions do not exist, a non-pathological compensatory left AIC pattern individual should have increased FAIR on the left and increased FAER on the right to near normal values compared to before repositioning. If capsular and soft tissue issues exist after repositioning secondary to overcompensatory activity, a non-pathology compensatory pattern can now become a pathocompensatory pattern.
Okay, go to the next slide, please. So we're asking you to take goniometers and measure range of motion values before and after you reposition. And we don't even know how to reposition. That'll be tomorrow. We'll reposition our walls tomorrow, okay? Today, we're just gonna get through the test. So that value should change after you reposition. And we'll do these two gals tomorrow. We'll reposition them and show you what we got, but there should be a change. Can you hit the next slide for me, please? So before we do lab, we did in your manual, what page is this on, Jen? Honestly, guys, I think one of the two coolest pages in the manual are 38 and 39, if you want to know the truth. We just rewrote these, pages 38 and 39. Katie, tonight, if you guys had any homework tonight, besides writing a question or two, could you review 38 and 39 before we come back tomorrow? Because, Pat, that's a lot of material in one day. So we're really done didactically for the course today. But I would like to have you reread 38 and 39, especially this box right here, and see if it really does truly make sense for you tomorrow morning when we start up. Because we'll start right here. The discussion we had with regards to rotation, I think we've outlined pretty well. But let's look at this. AF and FA treatment rationale for the left AIC pathocompensatory pattern, which means it's more kind of like a Lydia. There were some tests that were probably not positive like they should have been, okay? On the left side, you have left decreased internal rotation versus the right. On the right side, you have right internal rotation increased versus the left. And we're giving you the reason that Katie read, and I want you to reread it tonight. Why? Why did that occur? Okay, we went over it today, but I'm going to ask you to rethink about it tonight. Next slide. Then I'm going, wait a minute, it says left external rotation decreased versus the right. And right external rotation, increase, I'm sorry folks, increase versus right external rotation decreased versus the left. Why? Why did that occur? Why would that occur? We went over the reason why, but why don't you reread it so you can see what this hip capsule, this ligament, this iliofemoral ligament and the inferior capsule does on one side, and what's going on the other side, the ischiofemoral ligament capsule on the other side. If there are no questions, then I know we've covered it, but I would love to entertain some questions if you have any, because quite honestly, that's where we should be today. If you have capsular ligamentous issues and a capsule limiting your ability to ER and IR correctly, as written, and we don't take care of that issue somehow with a treatment program, then what we're going to do is we're going to run into your body's need to compensate even more. Therefore, tomorrow there'll be 2 treatment protocols we're going to follow for both non-patho, Katie, and patho individuals. We kind of got a non-patho person right in front of me, which is I'm so glad you came. And we got this kind of patho person over here, kind of. We'll talk about her. And I think it'll make more sense when we go through the algorithms, Ben, that reflect these 2 ladies. What would you do with Lady B versus Lady A? One that's really not patho and one that is kind of patho. And you'll see why when you rethink this thing through for tonight and tomorrow. Jen, how did I do there? Is that okay?
So before you go home, just underline on page 39, but highlight the word after repositioning. This chart is showing, like, if you still have these limitations after repositioning, this is what you need to consider, is what it's looking at. So that's what he wants you to review. So right underneath where it says soft tissue pathology,
It says soft tissue pathology right here.
after pelvic repositioning. So
And underline the word after. So make sure that when you read it, if these things exist after you reposition and get neutral, you understand, and it'll make it so much easier for me to bring this slide back up tomorrow and entertain what's going on. And then that sets the stage for the entire day. What treatment program would we use for Lydia, and what treatment program would we use for Katie? It'll set the entire day up for you. So let's take the 20 to 30 minutes and spread out and get your table set up, and we'll walk around. Jen and I will walk around and help you out. Let's make sure you understand how to do these 4 to 5 tests, okay? Before you go home, all right? So clean off the tables and we'll start up. Yes, question?
Well, I thought with her being at about 100 degrees on straight leg raise and having...
Listen to the question. She said,
She was partially kind of heading towards path.
Karina got a great one. She's beginning stages of pathology because she's got a little more than 90 degrees, but I think once we get her hamstrings fired up, that won't be an issue. You're right. She's getting, and it's a great question, she's starting to get into a little bit of what? Too much laxity with her straight leg raise.
Okay, so you don't worry about saying it's patho until you've
Yeah,
repositioned.
right now- and
Those beginning tests really don't matter until the reposition.
Let's record what we got. And did you hear what Jen said? Let's go home, think about we reposition this lady somehow, and now the tests come out which way? The way that we're talking about in the manual, and then we'll know what we got. Okay? That was a great question. Clean off the top of the table. Start off, you don't really need to start off in any order, but why don't you kind of go over the order that Katie and I went over with you. The first one would be the adduction drop test. The adduction drop test, okay? Really skinny, really thin, bigger hips. You'd want to put a towel underneath that thorax to kind of keep them straight. You're borderline skinny. So what I would do is, thanks Matt, to really do a good job, you would do something like this, because see what I do there? It just feels, do you follow me? Yeah. Let's do it again.
There you go. Now if you don't, if I don't let you pop out.
And I bring him into flexion, abduction, and he's definitely making it. He's definitely making it. Okay, nice job. Keep going. Keep going. Let's go ahead and lay him on his back and do the extension drop test. The extension drop test. Scoot him down this way a little bit. And yeah, and what you did is you took up the slack. Jacob, can you feel that? She brought it up. She backed it off. And you're fine. Right there is where I would put him. And you hold this leg, guide this leg straight down. And I would put your hand underneath of it, Lydia. And I got him straight down. Just, there you go. Keep going. Keep going. Got him down. And there. So he's a little bit soft tissue restricted, but he's horizontal. That would be a negative test. A positive test we'll show you when we find one, okay? So far, Jacob, you're looking pretty good. And I would never drop it, Lydia. Just guide it down. Stay in control. Just stay in control so you don't, there you go. Perfect. Negative, negative. Okay? Let's do a straight leg raise. Should we do a straight leg raise? Okay, so that's probably about, what do you want to give him, 60, 70 degrees? Okay. Is that about right, Jacob? Okay. I'll get out. No, Lydia, go ahead. Yeah, go ahead and go over there. Relax. So 70 degrees. Now, tomorrow, remind us that you had 70 degrees of straight leg raise, okay? Because that's not a negative thing. That's a negative thing. It only tells me that you're still not allowing your pelvis to posteriorly rotate enough. In other words, your hamstrings probably are good and active, but you're still too far what? Forward. So we want to get more what out of you? Extension. But so far so good. And it may truly be he's been sitting all day long.
Right.
So what would be cool is the minute he gets here in the morning, put him up here and recheck it. It'd be kind of cool. Wouldn't it be cool just to see, because you've been sitting all day long? Let's do trunk rotation. Nice job, Dallas. That's a great job. What I like about Dallas is not dropping the leg. Drew, he held it. Dallas, you didn't drop it. What, was he positive or negative on both sides? Right. Yeah. Positive on the left, negative on the what? And what I liked, you didn't drop it. You held it in control. So that was really good. Here you go. Go ahead and here's your trunk rotation. Go ahead. And is that left trunk rotation or right trunk rotation? Correct. You're doing a great job, Lydia. You're staying in control. You put this up there. Go ahead now, just kind of guide him down. And you can now, don't let go of this, but you can let go of that. Hold this, just, that's right. Run your hand down. Go straight across. So what I do is I put my hand here, put your hand here, use this, and you can just use your arm to guide. So there's the top of his leg, and if you look, do you see that? So what would you give him if that's the top of your leg, your arm laying on it? What would you give him about?
Probably about 13.4.
I give him 13 and a half. Do you see what you're doing with two things going on there? So he's got 13 and a half inches for right trunk rotation, okay? And if it was a typical person, that would be limited more than the other way. Okay, so let's see what he has on this side, okay? Do the very same thing. Why don't you come on over here? Do the very same thing. Okay, does that feel different to you? Feels the same to you. Let's see what you got. Boy, he is spot on, Johnny. I mean, we're talking 14, real close. Yeah, so he's close, okay? Doing really good. The only other thing I would do, let's put him over the edge of the bed and sit him there and let's do, got a fly flying around. Let's do internal and external rotation. Have you done this before, Lydia? Have you done any of this before?
I have.
Okay, let's see what you got here, okay? So Drew, when you hold him down, Drew, is he limited more in one direction? I'm just curious. Because I can see it from here. So he's that would be left trunk rotation is limited. And go the other way? So there's something, and again, Dallas, I don't know, does your back bother you, Dallas, at all? So he's got a little patho going on with his back. Was he a positive adduction or positive Thomas? Positive adduction or positive extension?
For the Thomas.
And what about adduction drop?
No, I didn't really find anything with the adduction.
Okay. I want to see do the adduction drop test again for me. Lydia, just for me. Yep. This is his left, or this is his right adduction drop. Okay. That was perfectly done. That's negative. Flip them over again. Thanks, Dallas. Relax your head, Dallas. Flexion, abduction. And what's happening is, and I'm not trying to be critical, this hand here, can we do it again?
Yeah.
Keep him right there, Dallas. Don't let it move. Just don't let that move. See how that's, do you see what I'm saying?
Yeah.
Just hold it. Just don't let it move. Because what's happening, you're letting this go down. So that would have been see the difference?
Yeah, that's totally possible.
Do you feel the difference? Do you feel it, Dallas? Mm-hmm. So that's, because based on what you told me, that should not have dropped.
Yeah.
Does that make sense? Good job. What do you got for rotation, okay?
internal, he had about 30 degrees.
30 degrees, okay. 30 degrees of internal rotation. And what does he have for external rotation, Lydia? So you just drop it down there. There you go. 35, 40. Okay. So he's got a snug hip because he's neutral. So he's got a snug hip. He's got 35 of internal, about 45 of 35 external. Okay. Okay. So let's go to the side. And again, you've been sitting all day, Jacob. I guarantee in the morning I'll be different. Guarantee. 38 of internal. Of external, so he's got a little less external. But truth be told, do the external again on both sides. Do it over here. Tell me what you got over there. You're pretty close. I just want to make sure we're doing the same thing correctly. 30. See how close you are. 5 degrees. Take her. Would you agree? Mm-hmm. They're pretty close. And again, I think you're a reflection of somebody who's been sitting all day long. Mm-hmm. I think you're in pretty good shape, Jacob. Really, to be honest with you. We'll use you for the adduction lift score testing tomorrow. I'm going to show people off, okay? Can I show you what's cool about Jacob? Lay on your left side. This is what's cool about Jacob. He's been sitting all day, but look at this. We'll get it. Just relax. Just relax. There you go. Okay. So here's his abduction. 45. Lay on this side over here for me. Jacob, can you flip around for Don? Yeah, there you go. And just relax, okay? So see how even he is? He's completely neutral. So what we're seeing as far as limitation is because of his position he's been in all day. Since he has 45-45, I'm pretty sure he's symmetrical. He's right where he should be. That's what's so cool. We'll use you for the adduction lift test tomorrow. Okay. Would you already know her. You already know her. I wanted you to show me on one of these guys. Let's take this guy right here. Carl, come on over here. I want you to show me an adduction drop test on Carl, okay? Carl, he's going to use you, okay?
Right or left?
Right side, lay on your right side. Screen up, I got time. Screen up. Here, I'll do a 99 reposition real quick. Okay.
We gotta get a couple more groups. Let's do the repositioning. We'll do it in the morning.
Okay, because if you want me to do it tonight, I will.
Let's do it in the
Okay.
morning.
Okay. 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 I just want to make sure you get done what you want done. Okay. Okay, so. Okay, now here's what I would do differently. Because see what you're doing now is you're kind of pulling the femur around. So that's why I wanted you to see. I'm stepping on your phone. I hope I didn't hurt it.
That's all right.
Okay, so I wanted to see you do it. Okay. So you're going to put your hand here. Remember, this is a long leg. So you're going to take this leg, you're going to bring it into flexion, bring it up, and boy, feel that restriction. Oh, pop, click. So I can't even get him up in the abduction. He's so tight in his adductors, which means that's all he's got right there. He's pretty sad. This is a sad case. Okay? But do you feel it?
Oh, yeah. Oh, yeah.
So I want him to feel it. Is that okay?
Oh, yeah.
So go ahead and do that again. Get him closer to you. He's a long guy. You're going to be working with a lot of these kind of athletes.
Right.
You know that. So take control of this femur. Sandwich this femur between you and the knee. Got it? Bring it up. But bring it up. Bring it up. Now, bring it out. Do you feel how restricted that is? And then keep bringing it back. And see how he's just dropping all the way down there? So I don't want that. So you gotta stabilize that rear. Get your hip in there. See, he's done. You follow me? You can't even bring it back.
Right.
But you can't even bring him up. Does that make sense to you? I'm picking on you because he's bigger than you.
Yeah.
Flip around and do the other side. I know the kind of people you're going to be working with. You follow me? I know where you came from. So same thing. Sandwich. Get your rear in there. There you go. Raise it up. Bring it back. You're doing a much better job. But see, you can't even bring it back. You're not even back to neutral yet. Can I check it myself? Here's what I would do. Boom. Got it. I'm going to sandwich him in it. I'm going to pull it in. Bam, bam. Lift it into flexion. Lift it. That's all he's got. I know I'm in trouble because I can't get any more than that. Then I'm bringing him back. Look, I didn't let that denominator burn. That's all he's got. Anything more than that? Bam. So he's sad. Really sad. So let's go over there. Go over the edge of the bed, Carl. Okay, so this should also be positive because I kind of did an extension drop test on him. Am I picking on you too much?
No.
Okay, Carl, lay back on back, okay? Scoot back a little bit, Carl. Okay. Now here's another difficult situation, long femurs. So you can get your hands in here, and since he's gonna kick you in the face, get over to one side, left side. And then when he lowers, I'm gonna take in control. I'm gonna first of all get his back where I want for neutrality, right there. Sometimes I'll ask for a second person, which I'm gonna be, okay? So come on over here, put your left hand here and check the right side. Put your left hand right here. So you go ahead first, and just stay in control. Don't let it drop. Stay in control. That's what he's got. He's now really technically, okay, I'm hanging around the weight room with you, or I'm hanging around the training room. You say, Ron, come on over here. Stabilize his left side for me. So I'm stabilizing his left side, okay? And we're gonna do the very same thing. I got him. Jacob, I got him. You got control. I got him. There, now keep the knee bent. Don't straighten out, keep the knee bent. Bring it into the midline. And see, do you feel that test? And Carl, do you feel that?
Oh, yeah.
It's just so stinking tight. Yes. Now watch that, keep him right there. Watch this. If I drop, let that go, he goes straight down. Do you follow me? Yep. So you're gonna need probably 2 people on this guy. Let's check the other side. I come on the other side, I'll help you out. You see why? And I know, Lydia, you're around people that are really, really tight too. So sometimes, I mean, big athletes. So you gotta hold them. I got him over here. I got him for you, okay? Yep. You see how that helps?
Yeah.
There's that positive test. So you're gonna need some help on this guy, right? Do you feel the difference between the two sides? So it's cool. Let's keep going. I want you to tell me what his rotation is right here, okay? And we'll be done.
Trunk rotations? Or no?
Don't worry about trunk rotation. I want to see what IR is. Carl, I'm not picking on you. I really wish you were here tomorrow. I really do. I really, truly do. Scoot back a little bit, because I think we could. Okay, what do you got here?
Got about 25.
Okay. Normal's about 40.
Right.
So he's about halfway. Okay. Okay, a little over halfway. What does he have over here on this side?
25.
Okay. He's only got another at least 15, 20 degrees to go, you know what I mean? Let's check ER out.
What do you tell him to do with the other foot?
Good question. If he just keeps it, just good question.
Yeah.
Concentrate on keeping this foot where it should be.
Okay.
It's a very good question. He's doing about the best he can. I'm helping him.
Yeah.
He may need somebody in here to see what I'm doing here, Carl. It's a good question.
About 29, 30.
Okay, so he's really tight.
Right.
Okay, let's check this guy over here. What do you got for external rotation on the side? See what I'm doing for you?
Yeah.
See, because if I'm not around, he'd have to kind of just make sure. Oh, now you're way off here. Put this here. There you go. Which one do you use your arm? There you go.
About 20.
There you go.
25.
30. Okay. So he's limited. He's really limited by and he should be with what we have going on here. Here's the good news, and I'm going to say this in front of this lady, okay? Come on over here. Between these two patients, who would you want for a patient?
Probably be easier to work on her.
Well, why? Because she's prettier or what? No, actually, I tell you why. You'd want to probably work with her because she's a little bit more loose jointed. She's easier to work with as far as soft tissue. Personally, I would pick that guy because he's more intact than she is. Is there any pathology on that gentleman?
No.
None. He has no pathology. He's a good-looking, tall guy with a tight hip and a tight set. Is he loosey-goosey?
No.
Before you go home back to Rhode Island, as a student here, we're going to get you shifting, and we're going to get what position? What position are we going to get you in?
Left AFIR.
And what position are we going to get you to do that in?
Left stand.
90-90s. We're going to get this guy to go for, we're going to make him drink, eat, and sleep on 90 what?
90.
So he can get that hip capsule back. This lady has got a little bit more problems because she could do 90-90, but what does she need to stay stable? More what? Don't say hamstrings. Could use it.
Glue max.
Don't say glue-max. More what? Internal rotation. She needs anterior glue-min, and adductors. Big time. You have them, you just can't find them.
Yeah.
You're too tight in the what? Hips. She's loosing her hips. Between the two, I'd rather have him. I can't believe I said that either. Okay? Because your problem is you don't need anybody. You're doing pretty well. She may not even she may not even want to do her exercises because she's doing pretty well. Where you're feeling a little what? Tight, she feels what? Pretty cool. Loose. She's doing great. But she would be a tougher one to manage because I got to get glute med, glute min, anterior fiber, IC adductors, and then I got to make sure she has it when she pushes off because she's bilaterally not kicking her hamstrings. Now the good news about her is she didn't go past 60 degrees, 70 degrees straight leg raise. Her hamstrings should be really cool for her to get herself out of it, which we'll use her tomorrow. But she needs a lot of internal rotation. You need a lot of what? Shifting. You need a lot of shifting. Did that make sense to you, to all three of you? Thanks a lot for your help. What would you like me to show?
The tester. Just go through each tester so we have another view.
All right, one more view, okay? Do you mind?
No,
You
I don't
Pat?
mind at all.
Katie, I'm going to watch you,
Okay,
okay?
lay on your side. We'll do the adduction test first.
All right. Okay. Okay. All right. Katie, here's what I would do, okay? I would get my hand, I'd get her closer to you. Come over here, Pat. And I get in there, and I just, first of all, just get a hold of her abdomen, okay? So you put your hand on her abdomen, take this hand, and just pull her into your tummy. Take her up into flexion, up into abduction, and then look at my left hand. Do you see how it's not moving at all? It's still not moving, still not moving, still not moving, still not moving, and she's negative. And I knew she was going to be negative, but you're too sloppy here. So really keep this secure.
Okay,
Keep
let me
it secure.
try that again.
Just don't be afraid to manhandle it. Just really manhandle it. Keep it.
Good.
And you're going to have to go slow. Don't let her do a lot of the work. You're going to guide her. You're going to lift up. You're going to bring it back. Go slower, Katie. Go slower. Go slower. Go slower. Right there. Got her? I'm going to let go. Don't go down yet. Just do you have control over her? And then drop her down. That's what I would do. If she starts to externally rotate, you might consider doing this. Do you see where my hand is? Doesn't that feel better, Pat? Yes, it does. So if she's starting to externally rotate on you, get under her and then hold down. Does that make sense?
Okay. Let me know if my hold's very different.
And go slow. Very good. Didn't that feel good, Pat? Got it.
You almost give her a little compression.
Yeah, pull her in there. She knows what you want. She knows what you want. Flip around and do the other side, okay? Just thank you for helping her out, Pat.
Yeah.
Pat, did it go good today?
Yes,
Learn
it did.
something?
Yeah,
Okay,
it wants to
good.
be a PT now.
Yeah, scoot over towards you a little bit. You guys saw each other last week, didn't you?
We do. We've been spending on it.
Yeah, you're
good
following
friends
each
now.
other, yeah.
Yeah.
Oh, wait, hold on. I gotta get this guy up here.
Yep. Secure, manhandle, up. And again, what you did there, let me criticize you a little bit.
Yep.
You went into flexion, stop, take her up into abduction, stop, take her back into extension, stop. When you go slow, keep going. Now drop her slowly. And she is definitely going to be negative. I can already feel it. Now, how can we do better there? What can we do better? She's still externally what? Rotating.
Maybe get her top over here. a little
Yes,
bit
ma'am. Very good. And get your femur, get her tibia underneath your forearm.
better. Oh, that's
There you go. Now try it. Oh, you nailed it. Pat, did you feel that?
It feels way
Nailed it.
different,
Feels
yeah.
so much different, doesn't it?
Yeah.
And here's the deal. She may not go all the way down, but she can adduct. If she couldn't adduct, she would stop. But since she's moving through it, she might be, her soft tissue might be a little restrictive, but she can osseously what? Adduct.
Adduct.
That's the
So
question.
she-
Can they adduct?
Okay, because I first thought she was positive, but she's actually negative on
Yeah,
that side.
because see, you could move her. You could move her into adduction, so you know there's not an osseo. Now she's tighter over here. There's no question about it. You feel that, Pat? But she can adduct, so it's going to say, "Can you adduct?" And look at Pat. The more I work with you, the more I can get it. Do you follow me? You kind of know what I want you to do. I don't think we need to do the extension drop, but I do want you to do trunk rotation on her because I
failed it.
Yeah, can I see it? Can I see it?
Opposite.
Yeah.
Maybe I didn't know.
And that's what I think about her. I think, do you mind? And we'll let you guys go.
No, this is great.
Do the trunk rotation one on her, okay?
Yeah, we were talking and imagine that she might be upper.
Exactly.
brachial
That's where I
first.
think you're at. Because this is a dental hygienist used to be, right?
Well, 3 months ago, yeah,
Yeah.
I retired.
Oh, yeah. So there you go. Look at all that rotation to the right. I mean, she can go forever. Do you follow me? And then go the other way. We won't even measure it. We won't even measure it. Just go ahead and go over here. So there could be some low back issues, some mid back issues, some torso issues, some way too much. It's limited, but it's still, look, can I show you something? Hold it with your hand. Way too much. You know, she just goes forever. Do you follow me? But it is limited, and that would be the reverse of what we normally
Yeah,
would
because
see.
I thought it was more reverse than what we
You
usually
are
see.
correct. So that'd be a low path, though. What was her straight leg raise like? Show me your
Limited
straight
on
leg
the
raise.
left.
Okay. And I tell you, that's a good sign, Katie, because if it's more limited on the left, you can do a lot for her. If it's more limited on the left, but you know what? She's I mean, really, she's treatable. It's not like her hamstrings are gone. You know, I don't know if anybody in this class will have hamstrings that are gone, but if she can stay at 90 or below, man, this is great. This will be a great program for them. Hamstring and frontal plane.